Okay, so if you're a dental professional, getting consent is just part of the daily routine, right? But are we really hitting the mark? I mean, beyond just getting that signature on a form. Let's break down what you actually need to know to make sure your consent process is not just ticking a box, but is truly centered around your patient. So here's what we're going to cover. First, we'll look at why this is all so important. Then, we'll get into the real nitty-gritty. What makes consent legally valid? We'll walk through that crucial conversation you have with your patient, touch on the tricky subjects of capacity and treating younger patients, and then we'll finish up with the one golden rule that protects absolutely everyone: documentation.
All right, let's dive right in. So, why do we talk about consent so much? Well, it goes way beyond just paperwork. We're talking about fundamental legal, ethical, and professional obligations that are at the very core of what we do.
And look, this isn't just a friendly piece of advice. The General Dental Council, the GDC, lays it out in black and white in Principle 3. It is a non-negotiable standard. It sets the stage for everything that has to happen before you even think about starting treatment. The Care Quality Commission, the CQC, really hammers this home with three main points. First, and this is a big one, it's a legal requirement to even touch a patient. Without it, you could technically be looking at assault. Second, it's all about autonomy, respecting a person's absolute right to decide what happens to their own body. And third, just on a practical level, everything goes smoother and you get better outcomes when patients feel like they're a part of the decision. So we know it's a huge deal, but what actually makes consent, well, valid? This is the foundation for everything else, so let's get this right. It's a word we throw around all the time, isn't it? But what does valid really mean in this context? Well, it all comes down to three key pillars, and you need all three of them. Miss one, and the whole thing falls apart. First up, it has to be voluntary. This means the patient is making the choice completely on their own. There can be no pressure, no coercion, not from you, not from their family, not from anyone. Second, it's got to be informed. And this is crucial. Your patient needs to have all the important information. We're talking risks, benefits, what the alternatives are, and yeah, even what might happen if they choose to do nothing at all. And pillar number 3, the patient has to have the capacity to make that decision. This just means they're able to understand the information you've given them, hold on to it, and use it to make a choice. Okay, so keeping those three pillars, voluntary, informed, and capacity in mind, let's talk about where it all comes together, in the actual consent conversation. This is where the theory becomes reality, right there in the clinic. You can almost think of this as a mental checklist for your discussion. You've got to cover all the treatment options, and of course, your recommendation. You absolutely have to explain the risks and the benefits, what might happen with no treatment, the full cost, and any guarantees that might apply. The goal here is a full 360-degree picture for your patient. Now, this is a point from the GDC that is so important and honestly, so often overlooked. That signature on the form, it's evidence, sure, but it is not the ultimate proof of valid consent. What really, truly matters in a legal sense is the quality of the conversation you had and how well you wrote it all down. This leads us into a much trickier area. How in the world do we actually assess a patient's capacity to give that consent? Because let's be honest, it's not always a simple yes or no. For those of us in England and Wales, the Mental Capacity Act of 2005 is our guidepost. It gives us the whole legal framework. And one of its key principles is this: you must always start by assuming a patient has capacity, unless you have evidence to show that they don't. The Act itself gives us a very clear definition. A person lacks capacity if there's some kind of impairment, and it could be temporary, like from medication, or permanent, like from dementia, that stops them from making a particular decision at that specific time. And that leads us to this really useful two-stage test that the CQC recommends. Stage 1, is there some kind of impairment of the mind or brain? If the answer is yes, then you move to Stage 2. Does that impairment actually prevent the patient from being able to understand, retain, weigh, and communicate the information for this specific decision? Okay, another area that requires some careful thought is getting consent for our younger patients. The rules here are very specific, and they really depend on the patient's age and, their level of maturity. So the law basically draws a line in the sand. For 16 and 17-year-olds, it's pretty straightforward. They are legally presumed to have the capacity to consent, just like an adult. But for children under 16, it's different. They can only consent for themselves if they pass a test for something called Gillick competence. If they don't, then you need to get consent from somebody with parental responsibility. So what on earth is Gillick competence? Well, it's a legal standard used to decide if a child is mature enough to make their own decisions about their medical treatment. And hey, these criteria should look pretty familiar, right? They're almost identical to the test for adult capacity. Can the child understand, retain, use the information, and then clearly communicate what they've decided? Right, we have covered a lot of ground: the why, the what, and the how of consent. But honestly, none of it really matters if you forget the final, and I would argue, the most important step of all: documentation. And once again, let's go straight to the GDC. They couldn't be clearer on this. Keeping complete and accurate records isn't just a nice to have, it is a mandatory part of your professional duty. And that absolutely includes documenting the consent process every single time. So look, if you take away just one thing from all of this, please let it be this: your clinical notes are your absolute best friend. They are your best line of defense. They have to show what you talked about, what the patient understood, and the choice they made. Because at the end of the day, it is that documented conversation, not just a lonely signature, that proves you obtained valid consent. And that really just leaves us with one last question for you to think about when you're back in your practice. Take a hard look at your current process. Is it really robust enough? Is it protecting you and your registration? And just as importantly, is it fully respecting and protecting your patient's rights?